In this section, we'll review the management of hemorrhagic stroke. There's two main types of hemorrhagic stroke. The first is intracerebral hemorrhage, and this is where an artery within the brain ruptures and causes a bleed. The other kind of hemorrhagic stroke is known as subarachnoid hemorrhage, and this is when an artery on the surface of the brain, which usually is an aneurysm, ruptures, and this leads to blood pooling on the surface of the brain in the subarachnoid space. In both of these types of bleeds, the direct contact of blood with the brain tissue irritates and damages the brain cells. So we'll start off first with a review of intracerebral hemorrhage, or it's often called intracranial hemorrhage as well. And as we mentioned before, this happens when a blood vessel within the brain ruptures, resulting in blood leaking inside the brain, and this compresses the tissue and causes a sudden increase in pressure. Symptoms of an intracranial hemorrhage include headache, vomiting, and altered level of consciousness. Patients also present often with elevated blood pressure because this is the most common risk factor for developing an intracranial hemorrhage. If you look at the overall incidence, it's only 9%, so much lower than ischemic stroke, but it is notable that intracerebral hemorrhage is the most fatal form of stroke. Up to almost 50% of patients die from this type of stroke, and 80% never regain full function. So it's a very debilitating type of stroke for those patients who do survive. As far as risk factors for intracranial hemorrhage, I mentioned that hypertension is the number one cause of intracranial hemorrhage. However, patients who are on anticoagulation, such as warfarin or the newer oral anticoagulants, for example, also are at risk for developing these types of bleeds. Once patients are diagnosed with intracranial hemorrhage, treatment really centers around trying to stop or slow the bleeding with either blood products or some reversal agents that we have available. And in general, we're just trying to manage any other complications and provide supportive therapy. Currently, warfarin is the most common cause of anticoagulant-induced intracranial hemorrhage, and it accounts for about 12 to 14% of cases. As Dr. Bassel mentioned, your INR, as it increases your risk of bleeding, and the risk of intracranial hemorrhage doubles for every half a point for an INR greater than 4.5. The American College of Chest Physicians provide guidelines for management of elevated INR, and you can see from this chart that depending on what your INR value is, you're either going to lower or hold your warfarin dose and possibly give vitamin K either orally or intravenously. In the case of intracranial hemorrhage, we're looking at a serious or life-threatening bleed. So regardless of the INR, you want to hold warfarin, give intravenous vitamin K, and some sort of factor replacement with either FFP or prothrombin complex concentrates, which we'll talk about over the next few slides. So vitamin K is a quick review from Dr. Bassel's lecture. Vitamin K is an essential cofactor of factors 2, 7, 9, and 10, and some of the anticoagulant protein CNS. And as a review of the mechanism, oxidized vitamin K is converted to reduced vitamin K by vitamin K reductase, and this is the enzyme that's inhibited by warfarin. The reduced form of vitamin K can then convert inactive factors to activated factors, which can then participate in the clotting process. Kinetically, as you recall, vitamin K is a fat-soluble vitamin, so we get most of it from our diet or also synthesized from our gut bacteria. Even though it's a fat-soluble vitamin, it does have lower body stores than other fat-soluble vitamins because it's rapidly metabolized in the liver and then excreted in the urine, also the bile. One thing to note about vitamin K is it has a very long half-life, so that's something to consider when we're giving it to patients who are on anticoagulation and may need to resume it later. You may see some resistance when you restart the anticoagulant. Vitamin K can be given in a variety of routes, including oral, subcutaneously, and IV. If you look at the onset of oral vitamin K, it does increase clotting factors within about 6 to 12 hours, but probably closer to 12 hours. And to fully reverse the PT INR takes about 24 to 48 hours. So for this reason, it's recommended for patients with elevated INR without a life-threatening bleed. What about sub-Q and IV? Sub-Q typically isn't recommended because it has erratic absorption and it is a little bit slower than IV for the patients that you really are in a hurry to reverse their INR. IV does increase clotting factors in 1 to 2 hours. You can see much shorter than oral, and it has been shown to decrease bleeding in a little bit quicker time, but it still takes 6 to 12 hours. This graph shows a comparison study looking at IV and sub-Q vitamin K administration in patients with an INR greater than 6. And at each time point at 0, 8, and 24 hours, IV significantly lowered INR more compared than subcutaneous administration, but by 24 hours, even though it looks like there's a difference, it was not shown to be significant. So again, if you've got patients who you can wait a full 24 hours for INR reversal, oral would be preferred because they're all going to be about equal by 24 hours. But in the case of a head bleed like an intracranial hemorrhage where faster is better, that's when IV has more of a role. Some of the precautions for giving vitamin K are with IV administration. There is a less than 1% risk of anaphylaxis. And you can probably find this with just about any drug, but to be honest, this actually does happen in practice, and I've had it happen to me with a couple patients. So for that reason, it's a black box warning that you really do have to pay attention to. You can decrease the risk of anaphylaxis by diluting the drug in, say, like 50 mils of normal saline and infusing it over 30 minutes rather than giving it as straight drug as an IV push. That being said, I've still had patients anaphylax by doing so, but just something that you want to monitor every time that you do give IV vitamin K. The risk for anaphylaxis is another reason why, unless there is a compelling indication for rapid INR reversal, we typically give vitamin K orally. IM administration is another possibility. It does have less anaphylaxis than IV administration, but it also carries very erratic absorption and is uncomfortable as far as causing bleeding, bruising, or hematomas for the patients. So this route is typically avoided. The other thing, like I mentioned before, is that if you have patients who already have a hypercoagulable disorder or who are on anticoagulation that you wish to restart, because of the long half-life of vitamin K, you may see some resistance to the resumption of your anticoagulation for several days after vitamin K administration. So when you start to think about doses and therapeutics, we always want to give the lowest dose of vitamin K possible to reverse the INR. So clinically, vitamin K can be used just for nutritional supplementation in patients who are deficient in their dietary intake, but more commonly how we use it in practice is what we've discussed here for treating patients who have need for warfarin reversal, plus or minus the presence of a life-threatening or serious bleed. Again, for patients who have life-threatening or serious bleeding, that's when you would want to use intravenous vitamin K. If it's just an elevated INR that you want to reverse, then typically oral vitamin K is recommended. Prothrombin complex concentrates, also called PCCs, are products that are derived from human plasma, but they have factors 2, 7, 9, and 10, and also some of the anticoagulant proteins C and S. The product that's available now on the market is called Kcentra. It's also referred to as a 4-factor product because it's got factors 2, 7, 9, and 10 in it. And it's indicated for the urgent reversal of warfarin in adults with acute major bleeding. And as we just discussed with vitamin K, this product is recommended to be given with intravenous vitamin K. These products are very nice because they normalize the INR within minutes, so they're very effective for warfarin reversal. Another option for providing factors in patients with life-threatening bleeding is fresh frozen plasma, or FFP. If you compare FFP versus some of the prothrombin complex concentrates like Kcentra, you'll see a few differences. So PCCs have just the 4 factors, 2, 7, 9, and 10, whereas if you look at fresh frozen plasma, it pretty much has everything as far as the factors. So you're getting very complete factor replacement. One of the downsides, though, of FFP is it's just based on pooled donors. So the amount of each factor can vary greatly depending on the specific donor. Versus PCCs, they regulate it so that there's a certain amount in each batch. As far as the volume that's involved, FFP typically is a much larger volume total that needs to be given to the patient. This may be an issue, say, for example, on a heart failure patient who's already fluid overload and can't tolerate a lot of additional volume. As far as onset goes, prothrombin complex concentrates you can see are much faster. So again, you get INR reversal within a few minutes versus hours with FFP. Half-life is about the same for both agents, so that's not a big difference. And the other limitation of FFP is that it is blood group specific, so it does take some time to type and cross versus PCC, you can just reconstitute and give it quickly. So when you look at PCC and FFP, how they're both used is to correct INR, typically an oral anticoagulant intracranial hemorrhage, but it's also being used off-label for other types of bleeding as well. Although the newer oral anticoagulants or the NOACs have been very appealing because they require less monitoring than warfarin does, one of the limitations of these NOACs is that there hasn't been a reversal agent available. Some of the options that we've talked about, like vitamin K, PCC, and FFP, have not been universally effective for reversing the NOACs. So when Praxbine was approved, this was really the first reversal agent that was specifically indicated for the NOACs. Praxbine, the generic name is idarucizumab. This is a monoclonal antibody that binds to dabigatran and prevents its binding to thrombin. So it's indicated for dabigatran reversal in preparation for emergent surgery or urgent procedures or life-threatening or uncontrolled bleeding. The reversal effects of this agent have been observed by the end of the infusion and persist for up to 24 hours. So usually it's just given as a single dose. However, the manufacturer says you may consider a second dose if patients have continued bleeding or emergent surgery. This drug is really new. We've only used it a few times so far, so we're still getting experience with it. As far as adverse effects, so far it seems to be well tolerated. One of the concerns with any of these reversal agents is the risk of thrombosis, which is currently reported at about 4%.